Thank you for joining this webinar. My name is Gibril Ndow. I lead the Hepatitis Research Group at the MRC unit in the Gambia, and I am the co-chair of the Special Interest Group alongside Professor Manal. To get us started with this webinar, I will do the first of the three presentations today. I'll first be giving a brief reminder of the importance of eliminating mother-to-child transmission of hepatitis B, our status of where we are in Africa, and sharing very preliminary results from an implementation project that is currently ongoing in the Gambia, where we are trying to implement the triple elimination strategy within the existing services. The WHO had set very ambitious targets in 2016 to eliminate viral hepatitis as a public health threat by 2030. These targets include reducing new hepatitis B infections by 90% and reducing hepatitis B related mortality by 65%. The 2024 Global Hepatitis Report highlighted the significant variations in progress towards achieving these elimination targets globally. We found that the Africa region still represents a very high prevalence of hepatitis B, with about 65 million people living with chronic hepatitis B infection. But more importantly, about 3 out of 4 new infections globally are recorded in Africa, with the earlier reports in 2021 showing that about 1 million new infections are recorded, and the 2024 one showing about 750,000 new infections recorded in Africa every year. Public health interventions to reduce new hepatitis B infections in Africa has largely focused on eliminating early horizontal transmission, especially within household clusters and between siblings. This was a result of earlier studies which had shown the importance of these early horizontal transmissions in Africa, in contrast to the significance of vertical transmission that was shown in Asian populations. However, newer studies have shown the importance of these vertical transmissions in Africa as well, and have demonstrated that unless mother-child transmission is eliminated in Africa, the region cannot achieve the WHO elimination goals. Currently, it is estimated that 2 out of 3 new infections in Africa is acquired through mother-child transmission, and earlier systematic reviews done by Keane and Yusuke around 2015 showed that approximately 350,000 new hepatitis B infections are recorded in Africa through mother-child transmission. Of course, there is also emerging evidence that hepatitis B infections acquired vertically through mother-child transmission result in an increased risk of severe liver disease, need for antiviral therapy, and an increased risk of liver cancer in adulthood, all of which would increase the risk of mortality, thereby pushing the WHO elimination targets. Therefore, hepatitis B mother-child transmission elimination is a cornerstone for the overall hepatitis B elimination for Africa and needs to be prioritized. Modeling studies done by Shevanthi Nayagam in 2015-2016 showed that if we scale up infant vaccination to 90%, coverage of time hepatitis B birth dose coverage vaccination to 90%, and antenatal screening with prophylaxis to 80%, we can reduce hepatitis B mother-child transmission rates in Africa to the WHO elimination target numbers. Over the years, the WHO recommendations have evolved, initially in 1992 recommending infant hepatitis B vaccination integrated within the EPI services, then the recommendation for the time hepatitis B birth dose vaccination in 2009, followed by the first WHO recommendations of antenatal prophylaxis during pregnancy among highly viremic mothers or women who are antigen positive in 2020, and the more recent 2024 WHO hepatitis B guidelines that have maintained this antiviral prophylaxis during pregnancy for highly viremic mothers, but adding a conditional recommendation for routine antiviral prophylaxis for surface antigen positive mothers in settings where access to hepatitis B DNA quantification or antigen testing is limited. These recommendations complement the triple elimination recommendations by the WHO to integrate HIV, syphilis, and hepatitis B prevention of mother-child services alongside a larger context of sexual and reproductive health integration and linkages, essential maternal EMTCT services, and infant, child, and partner services. Current coverage in Africa for hepatitis B diagnosis and treatment remains poor, one of the poorest globally, with an estimated 4 to 5% of the individuals living with chronic hepatitis B being aware of their status, and 0.2% of the total number who are estimated to have hepatitis B infection having access to treatment, and only about 5 to 6% of those who are currently diagnosed having access to antiviral therapy. Coverage of timely hepatitis B birth dose vaccine remains very poor in Africa, with less than half of the countries in Africa adopting the timely birth dose policy. It is expected that more and more countries would adopt the birth dose policy in the coming years, with the support of Gavi support for strengthening and implementing the timely birth dose vaccine. To better understand where we are as a continent in terms of hepatitis B mother-child transmission and what needs to be done to meet the WHO elimination targets, Alex Stockdale last year did a large systematic review comprising 113 studies with a population of about 190,000 pregnant women across the different regions in Africa. And he estimated that about 6% of pregnant women in Africa were hepatitis B surface antigen positive, with some variation between the different regions in Africa. Importantly, this systematic review found that the rate of hepatitis B mother-child transmission has declined from about 1.2% of all live births, which represents about 340,000 new hepatitis B mother-child transmission events in 2001, down to about 172,000 new HBV mother-child transmission events by 2022. This represents about 0.4% of all live births being hepatitis B infected at or near the time of delivery. The study further and importantly found that if we're able to scale up timely hepatitis B birth dose coverage to 90% in Africa, this can lead to a reduction of 43.7% in the rate of hepatitis B mother-child transmission. In terms of actual numbers, that would reduce further the number of new hepatitis B infections at birth from 172,000 to 97,000 every year. If we're able to, in addition to 90% coverage of timely birth dose, add maternal antiviral prophylaxis, we can further reduce the rate of mother-child transmission by up to 86%. And this would bring it down from 172,000 per year to only 24,000 per year. And at this rate, Africa will meet the WHO elimination goals of reducing new infections. Now, the guidelines are clear. We need to integrate triple elimination. We need to implement screening of all pregnant women, provide prophylaxis for those who are tested positive, adopt the timely birth dose coverage, and implement the infant vaccination within an integrated setting. And these are the WHO recommendations. But how can we really implement these? What are the barriers? What are the bottlenecks? There is very limited data in Africa to show how well this can be integrated and what will be the facilitators and the barriers to this. To address these questions, the Gambia set up the triple elimination study, which aims to develop, implement, and evaluate a simplified, integrated, and coordinated strategy for the implementation of the triple elimination strategy in the Gambia. This study leverages global fund investments and current health system capacities in the Gambia and is led by the Ministry of Health in collaboration with partners at the MRC unit in the Gambia, the HIV and hepatitis B control programs in the Gambia, a civil society organization, the Young Gambian Moms, and external partners in France, the ERD, SESTIM, and Institut Pasteur, and the study is funded by Expertise France and Initiative. The study is also concurrently run in Burkina Faso with the same objectives, with partners in different sectors in the Burkina Faso health system and the Ministry of Health. Briefly, before I go into the implementation of the study, I want to give you a brief context of the Gambia. Prevalence of the three infections is relatively low compared to some other places, but still quite significant, with HIV prevalence ranging between 1 to 2%, 0.9% for HIV2, about 1.3 to 1.5% for HIV1. Syphilis prevalence, not well studied and documented, but estimated to be slightly below 1%, and hepatitis B surface antigen amongst pregnant women was reported at 4.5% in a large study of 10,000 pregnant women done between 2022 and 2024. Currently, antenatal screening for HIV is done routinely for all pregnant women through the HIV program, which is largely funded by the Global Fund. Syphilis screening has been introduced a few years ago using the HIV syphilis dual test kit and has been well integrated now. Hepatitis B screening is not routinely done, and it's only offered by facilities where they have access to it, or where there is a drive either by the healthcare providers or by the facility leadership. The Gambia adopted the birth dose policy, was one of the first countries in Africa to adopt it, but the integration of the timely birth dose has not been as successful. We recently looked at the trend of the timely birth dose coverage from 2015 to 2021, and we found that the coverage has slightly increased up to a peak of about 29% by mid to late 2021. But this continues to be significantly short of the 90% target. Even though syphilis screening during antenatal screening has been introduced through the HIV program, follow-up for women who test positive for syphilis has been haphazard, with most women who test positive for syphilis not having access to antibiotic therapy, and there is no access to hepatitis B, DNA viral load, e-antigen testing, or HPV prophylaxis within the routine standard of care within the government facilities. So the objectives of this study was to strengthen screening of the three infections. So strengthen screening for syphilis, but also to integrate and strengthen hepatitis B screening to become routine in all centers, and to improve access to measures to prevent mother-to-child transmission of these infections, which means to introduce, implement, and strengthen access to syphilis treatment for women who test positive for syphilis, and for subsequent additional viral load on e-antigen testing for hepatitis B surface antigen positive women, with access to tenofovir prophylaxis for those who meet the criteria. Alongside these, we had developed a training program for healthcare workers who are in charge of these maternal and child health services. We provide access to the treatment for the testing as well, and to raise awareness on mother-child transmission among women of childbearing age and women who are pregnant and attending antenatal services. The study in the Gambia is being conducted in 5 maternal and child health services in urban and rural centers, with a target population of 12,500 pregnant women and about 135 healthcare workers and 11 peer mediators to be trained and supported to implement this study. All women positive for either of the infections and their infants who are exposed to these infections would be followed up until 6 to 9 months after delivery to complete the cascade of care and to assess the impact of these interventions on reducing mother-child transmission of the 3 infections, with a specific focus on hepatitis B mother-child transmission. Prior to the start of the study, we conducted a cross-sectional survey that aimed to understand the level of awareness and knowledge and the preferences and perceptions of pregnant women, healthcare workers, and community health staff, as well as policymakers at the national programs and the Central Ministry of Health, in terms of triple elimination, with a specific focus on hepatitis B elimination of mother-child transmission. We then conducted quantitative cross-sectional studies amongst women who have recently given birth and healthcare providers to understand and document the current coverage of services for hepatitis B, syphilis, and HIV screening, prophylaxis, linkage to care, and subsequent cascade of care for these women, and a survey on the prices and cost of services in terms of what is available and at what cost and who pays for it, whether at programmatic level or out-of-pocket cost for the women and their families. We then initiated the strategy, which involves a cohort study where all women in this implementation site attending their first antenatal visit are offered screening for HIV, syphilis, and hepatitis B, following prenatal counseling, and then women who test positive for either of the infections are subsequently followed up. Women who test positive for HIV infection are linked to the HIV program, which is well established and well funded, and would receive access to all the subsequent tests and antiviral prophylaxis. Women who test positive for syphilis would be offered antibiotics treatment with 3 doses at least 1 week apart, and supported to also provide the test for their partners if this is feasible and practical. Women who test positive for hepatitis B, of the 5 sites where we're doing this study, in 4 of the 5 sites, the women would have subsequent testing for hepatitis B, viral load quantification, and those who have a viral load more than 200,000 would be started on prophylaxis. And in the 5th site, we trialed the test and prophylaxis strategy, where all women who test positive for surface antigen are offered hepatitis B prophylaxis without doing a hepatitis B DNA viral load. And at the end of the study, we would do another cross-sectional survey to assess the level of coverage of these interventions, the level of knowledge amongst healthcare providers, but also amongst women in the areas where we've conducted this study. From the baseline survey, we found that prior to the introduction of the study, HIV screening was routinely offered to more than 80% of all women attending their first antenatal screening. However, the access to syphilis and hepatitis B screening was significantly lower in some sites, with almost no pregnant women having access to hepatitis B screening in the year prior to the introduction. Most of the healthcare workers had received training on HIV in terms of counseling, post-test counseling, and how to look after a pregnant woman who tests positive for HIV. However, 65% and 83% of healthcare workers reported never having received any training to look after syphilis and hepatitis B positive pregnant women, or even how to administer the counseling or conduct testing. Likewise, when we did a pre-training assessment for these healthcare workers, almost all the healthcare workers scored excellent in terms of basic knowledge for HIV, but significantly lower for syphilis and hepatitis B. To date, we have screened about 8,000 pregnant women. Uptake for screening and acceptance for screening is very high, with most women, almost all the women, accepting to be screened for HIV, syphilis, and hepatitis at their first antenatal visit. Overall, about 5% of women screened have tested for at least one of the 3 infections. The majority of them testing positive for hepatitis B, about 3.2% of the women, 1.3% for HIV, and 0.3% for syphilis. Overall, of the 404 women who have tested positive for one of the infections, 364 of them have agreed to be included in this study for subsequent follow-ups and to monitor adherence and their cascade of care. Most of the women who were tested HIV positive were previously diagnosed and are already on. Among the women newly diagnosed with HIV, about 2/3 of them have agreed to be started on antiviral prophylaxis, with the remaining women opting to think about it or discuss with their partners before coming back. For those who've tested positive for syphilis, 17 of the 24 women have been successfully treated with antibiotics, with the remaining women declining treatment and prefer to discuss with their partners or think about it before they come back to initiate therapy. For hepatitis B mono-infected women, all the surface antigen positive women were newly diagnosed, with none of them knowing their status prior to this antenatal screening. In the 4 sites where we're doing the hepatitis B viral load quantification to determine eligibility for prophylaxis, we have been able to successfully offer viral quantification for all the women, and about 66 of the 262 women met the eligibility criteria for antiviral prophylaxis. In the test and prophylaxis all site, 85% of the women have agreed to start hepatitis B prophylaxis, with 15% decline in antiviral prophylaxis despite a positive surface antigen test result. The cascade of care data is only available for women who have agreed to be followed up after the initial screening and who are enrolled in our cohort study. But overall, from what we have seen so far, there is a relatively lower uptake to prophylaxis amongst newly diagnosed HIV patients, newly diagnosed syphilis and hepatitis B patients, with about a third of the new HIV and syphilis diagnosed patients declining prophylaxis or antibiotic therapy, and about 15% of the hepatitis B surface antigen positive women in the test and prophylaxis all arm refusing antiviral prophylaxis. I must stress here, however, that the uptake to prophylaxis does increase over time, as we have observed during the first phases of this study, where initially women might refuse following the new diagnosis, but would subsequently, in their second month and antenatal follow-up visit, agree to start prophylaxis or take antibiotic therapy for syphilis. So most of the refusals have been around the women wanting to discuss with their partners, or for those who are hepatitis B surface antigen positive in an arm where we're doing viral load, initial refusal for additional blood sampling for viral quantification, most of which is usually resolved by linking the women to a field worker or a peer mediator who would spend more time with them to discuss their diagnosis and the need for additional services. In the test and prophylaxis all strategy, where we have more of the women who are hepatitis B surface antigen on tenofovir prophylaxis, we have observed very good adherence to TDF during pregnancy. Refusal for women to take prophylaxis amongst this 15% is not well known, and we would study this further to be able to share more information around these. And there are a few unanswered questions that we don't know as of yet in terms of the logistics of stopping antiviral prophylaxis at the end of the pregnancy and monitoring of these women for possible flares after stopping, and how to integrate these within the existing services at these primary care sites where access to laboratories is not as available. I will end by just sharing this one slide here of a new study that we would be starting in the summer of this year. It is expected that more and more African countries will adopt the test and prophylaxis all strategy for hepatitis B prevention of monochild transmission. Already we've seen Malawi has adopted this. I believe Uganda has also adopted this strategy, and it might we might see more countries in Africa to adopt this. But there remains very important questions in terms of the effectiveness, the feasibility, the acceptability, the cost effectiveness, and the safety of this test and prophylaxis all strategy. Therefore, we are starting a study this summer in the Gambia and in Malawi, funded by NIHR, to conduct a single-arm, non-randomized, pragmatic implementation study to answer these questions, with the primary endpoint being the proportion of surface antigen positive infants tested at 6 months of age in a test and prophylaxis all strategy, alongside linkage to care of women after delivery to assess the rate and incidence of flares and how to manage them in a public health setting. I will end here. Thank you very much, and look forward to taking questions and discussions further. Thank you.